Good afternoon and welcome to this broadcast. For the next 2 hours, we're going to be having a discussion on matters to do with health. My name is Mwesije Walter and we have Maureen Nambalira on sign language. I have a couple of guests in studio and I'm going to introduce them one by one. Dr. Patrick Kagurusi, who is the country manager for Amrit Health Africa in Uganda, seated right here in the middle. We have on the extreme end, Mr. Dennis Chibira, who is the Executive Director, HEPS Uganda. And here with me in studio also, we have Paul Gabula, who is the Program Manager at ACHEST. Now, we are going to be joined by another two guests online. We have Mr. Fred Tabu, who is a Country Consultant for Results Development, and he does work under the Ministry of Health. We also have Dr. Isaac Orek, who is in Lira. He's going to be joining us there and telling us what the situation is on ground. Now, the health, these gentlemen here are part of a larger group that implemented a project known as the Health Systems Advocacy project for the last 5 years. And the project aimed to contribute to sexual and reproductive health and rights of people in sub-Saharan Africa through building capacity of civil society actors and health stewards, knowledge, technical skills and tools that are needed to develop and implement evidence-based advocacy strategies. And of course, the partnership, we are in 2020, draws to a close. It's time to reflect on the progress that has been made and the sustainability of the work that has been made, especially to strengthen the system that has been built. We have a video which was compiled from several districts where the project was implemented, and you will take a look and see what happened during the last 5 years, and we'll come back shortly for the discussion.
Reduced access to sexual reproductive health care during COVID-19 pandemic has had severe consequences for young people, especially adolescent girls and women. One such consequence is an increase in the number of unintended adolescent pregnancies, which in turn could increase pressure on girls to marry at an early age. Some reports, including that of the United Nations Population Fund, show a significant impact as a result of constrained access to SRHR services. Eastern Uganda, Busoga in particular, has had the highest reported cases of teenage pregnancies, with Luka district alone reporting more than 600 cases. West Nile and Ankole regions have also reported many cases.
Youth-friendly services cannot be accessed easily. Contraceptive methods like condoms cannot easily be got the way we used to. Young people have fear of going to the hospitals because they think that it is where COVID-19 patients reside, and they think that is where they would also get COVID from. We may not be having masks and we cannot access services that are in the hospitals.
Abalenzi bakozesa ino ebiragalalagala olwokuba nti tibali kujja ku masomero ate n'ebyokukola bitono babasibira waka.
The police has since received 4,442 cases of defilement reported between January and April 2020. This is an impact on sexual and reproductive health and rights. The crisis is affecting the delivery of sexual and reproductive health services around health facilities in the country, especially in the way they operate. Some have been closed as others convert to handle only COVID-19 related cases. The impact of the measures to manage the spread of COVID-19 disrupted the supply chains and restrictions to freedom of movement.
Young people, even other patients, feared to come to the facility because they thought maybe all the facilities have COVID-19.
In the time of the lockdown, the graph went down in the demand for family planning services and commodity services actually.
The consequences of that was, and yet some are yet to be seen, high numbers of pregnancies, infections with STIs and STDs. It put the lives of these, especially the young girls, at stake. Majorly, the problem has been the variety especially for sexual reproductive health services, even when it is the same for other services. But you know, when it comes to sexual reproductive health services, particular individuals respond, especially the women, on issues of family planning, respond to particular methods differently, others with adverse effects. So there's need for having a variety.
Helps Uganda, partnering with other organizations, including Amrit Uganda and ACHEST, implemented a 5-year health systems strengthening advocacy project to promote participatory advocacy for effective policy implementation in 6 districts: Kabale, Chisoro, Lira, Dokolo, Serere, and Soroti.
The project that we collaborated with Amrit is the Health Systems Advocacy project, which was meant to strengthen systems and also improve access to sexual reproductive health services and also support with the human resources for health, building their capacity and delivering sexual reproductive health services. And in particular for HELPS Uganda, our focus was on strengthening systems around supply chain for sexual reproductive health commodities or medicines. Yeah, that was our contribution and support to this project.
Specifically, this program on our side looked at strengthening health systems so that they can deliver sexual reproductive health and rights services, especially looking at the issue of having adequate, well-skilled human resources, having strong leadership for sexual reproductive health and rights, having adequate commodities in the health services, focusing on ensuring that the services are of sufficient and quality that meets the demand.
Ensure that family planning commodities are available in all health facilities and all the method mix are available, so that whenever a woman has already taken on a method, should at least always get that method to avoid taking on a second one, or even failing to continue with the method when it is not available in the facility. Then another issue was ensure that young people, adolescents, access reproductive health services and information, so that they don't mess up with their lives, so that they can also know what to do in case they have their body changes, in case they need information, where to access it.
Between March, during the lockdown, up to about September, we've had close to over 2,000 condoms dispensed, about 2,900 of them. And then about 1,400 users of family planning have been here in different areas, the IUDs, the Implanon, the Jardel, the Sayana Press. And so their advocacy has also helped us to make sure that we have the stock and eliminate stockouts.
Kabale district did not have any budget for family planning. Worked with them, worked with the district budgeting desk, and finally were able to include in 5 million per year for advocacy for family planning uptake.
Most of the family planning methods were not fitting these people. People were fearing to use family planning. When you go, most of the drugs were getting expired in the hospital.
Some health workers do not have skills for providing these family planning methods, especially long-term methods. But we were able to work with the project, advocate for this, and the district would take it up, looked for the other partners who would train. And I'm happy that most of our health workers were trained.
Youth champions have been trained to help us talk to these youth about the sexual reproductive health and where they can get the services, okay? And then we have the VHTs who are there, and those ones live in the community. So we need to continue sensitizing them on both issues of COVID-19 together with the sexual reproductive health, so that the services all flow at the same time, and they should get the right services at the right time.
Even without a pandemic, women in Uganda face barriers to accessing sexual and reproductive health services. COVID-19 has placed an extra strain on this issue, while many services shut down to maintain physical distancing and avoid further infections. Women still very much need SRHR products and services. Life goes on and sexual interactions continue, even amid the challenges COVID-19 presents.
Okay, so the last line in that video was that life goes on even amidst the challenges COVID-19 presents. And of course, COVID-19 did really have interruptions on our lifestyle in the entire globe. And of course, when it comes to countries like Uganda, you know, the effects could last longer and much longer than expected. But of course, access to sexual reproductive health services is important because it has a role in improving the health and the quality of life of the Ugandan population generally. And I know if you look at the statistics in our health structures, we still have about 336 mothers dying per 100,000 live births. And these are studies that have been conducted. And I know HEPS Uganda, you know, has, you know, conducted quite some studies. We would like to understand from the studies that you have conducted on access to reproductive health commodities, what did you find out?
Thank you, Walter. Over the last 4 or 5 years, we've been doing studies on availability and affordability of a basket of 53 commodities for sexual reproductive health. And this we've done in Kenya, Uganda, Tanzania, and Zambia. And what we have seen, and this cuts across the 4 countries we've been doing this work. What we've seen is that for contraception, there is relatively high availability in the countries, but Uganda has been lagging behind the other 3 countries. However, the targeting for this has not been adequate for particularly the young adolescents. And therefore, there's been a key challenge there in terms of reaching them, but also in terms of having safe spaces for them to be able to access these commodities. In terms of maternal health commodities, oxytocin and misoprostol for postpartum hemorrhage, that's when bleeding before or after birth. Those ones, in Uganda, we've managed to have those adequately available, oxytocin and misoprostol. But the key medicine that has been of challenge is magnesium sulfate, which is used in hypertension in pregnancy, or in other words, called preeclampsia. And this has mainly been because, first of all, health-seeking behavior. This disease is highly marginalized. When women get this disease, sometimes they gain weight, the legs will swell, and other effects that sometimes they think those are related to pregnancy. They just think that's because they're pregnant that they're getting these problems. And many times they present very late to the facilities, and at that time they are in coma or delirium. And even then, the health workers, the medicine that they use, the health workers have not been adequately trained to use this magnesium sulfate. And so lower level health workers have been referring to higher level facilities. And by the time the women get to these facilities, many times it's too late and they lose their lives. Yeah. So what we've found across the 4 countries is that we need to prioritize magnesium sulfate, the medicine for this preeclampsia, but not just in availing it, also in training health workers to be able to use it, but also in getting the demand side, in getting mothers to come for antenatal care and to be able to be tested so that the early signs are detected and the women get early treatment. When it comes to child health commodities, I think we need to do a lot more in terms of availing medicines for pneumonia and diarrhea. Those are the number 1 and 2 killers of our children. But across the 4 countries, these medicines have not been given adequate attention. So that's basically it.
Okay, so if we take a look at what the role of AMREF was, generally was, the overall and probably to provide guidance to the several organizations that you worked with in the last 5 years. We would like to understand what it was like, for you to actually filter out the organizations and make sure that the goal is achieved.
Thank you very much, Walter. AMREF, yes, may have been the partnership lead, but we had an equal partnership where the organizations that we worked with on the consortium had equal responsibilities and were pursuing the objectives they had on the project. That's one. Two, AMREF's implementation was mainly district-based.
Yeah.
And we went out knowing that for sustainability, would have to build capacity at district level, and that capacity would therefore retain the capacity when the project ends, like now. So we worked with the local civil society, CBOs mainly, one of them like Quid, you've just seen them presenting in the video there. Then we worked also with the district, local governments, and we strengthened the relationship between the civil society and the districts and the health facilities to form that network that would deliver sexual reproductive health rights-based services to the communities, to the beneficiaries. AMREF also worked with community health workers, and the reason for this, especially the VHTs, was that they stay closer to the community and form the linkage between the community and the health facilities and service providers. So we worked a lot with community health workers to bring the voice of the community to the health facilities and local government, but also to refer cases of sexual reproductive health service needs to the health system. We also worked a lot with the adolescents and youth-led organizations because our intention was that the youth are the ones who are bearing the highest burden of sexual reproductive health ailments. My colleague has already, in the video you already saw, nearly 1 in 4 girls by the age of 19 has either had a pregnancy or has had a child, and that's a big burden. 50% of all new HIV infections are occurring in this age group. And then our culture and the norms are that speaking about these issues is very difficult. So we had to involve the youth to be able to meaningfully engage their colleagues, but also with the local governments. We now leave a strong youth voice that understands the burden and are able to be able to champion the cause of youth accessing sexual and reproductive health services.
Yeah, and we know when you talk about the burden, we know that this has an impact on the universal goals, for example, like universal health coverage, on the way the country will achieve those specific goals, the SDGs that have been set globally. But if we continue at this trend, I don't know, you can tell us, Mr. Gabula, the trend that we are taking, are we too slow? Are we moderate? Are we improving?
Good evening, viewers, and thank you so much, Walter Mwesije. statistics shows that we are moving slowly, especially in sub-Saharan Africa. The pace at which we are moving, even if we spend the next 20 years conversing and debating this topic, if we don't accelerate our the way we are doing business, we will not achieve universal health coverage. I want to talk about a few things here. One is that when you look at, for example, every country in sub-Saharan Africa, we have national development plans, and we have the sector development plans, and these plans are well set out. They are very clear indicators, but when it comes to financing these plans, you very well know that most of our budgets come from donors. You very well know that the domestic financing of our budgets is really very, very minimal. So at the end of the day, it compromises the pace at which we implement activities. For example, when you look at the recent pandemic of COVID, it really compromised how much money the donors are committing to sexual reproductive health. We've had scenarios where funds for certain programs on reproductive health have been not diverted but shifted to other priorities like COVID. So this ideally compromises the pace at which we are moving. When you look at some of the international protocols that we are assigned to, like the Maputo Plan of Action, recently we did a study in 70 countries. But when you look at the findings from these 70 countries, the pace in all the countries where we did this study, including Uganda, Malawi, Tanzania, the pace is really very slow. So I think we need to really step up the speed. We need to finance more. We need to have more health workers, like my colleagues are talking about, well-skilled workers that are motivated to do a good job.
Okay, and Dennis, HEPS also conducted a study, and you had some results on the way government handles funding. And we have something that you referred to as credit line funding, where the government borrows to fund a particular project or a particular target. And you had some results which shows that for example, for ARVs, this has made some strides and improvements in the way those commodities are availed to the people and sustainably. But the results also showed that this has some challenges, because in most cases the unmet need continues to grow even when there are opportunities like that. What alternatives do we look at from the survey that you conducted?
For financing?
Yes.
So certainly, well, the government has made strides in terms, if you look at the health budget, it has grown. But in terms of what the actual, because the population is also growing. Yep. So the budget is not growing to the same level that it is adequate to meet the needs of the population. And so what can we do in terms of improving financing for health for the country? Certainly, users, if you look at that, there are three ways you can finance health. There is government financing, there is out-of-pocket that people pay, and of course you can go to donors. So in Uganda, about 40%, slightly over 40%, is paid by out-of-pocket by the users, but at the point when they need care. About slightly over 40% is also paid by donors, and government is paying in about 15 of every 100 shillings. And so what can we do? We need to ensure that we pool funding so that we are not, first of all, paying as and when someone needs that service. And therefore, health insurance would be one way to go about it. But also, there are other innovative financing that has been used by many countries. For example, taxing of, they call it sin tax, for taxing, if a portion of what goes maybe to people use cigarettes should maybe go to health. A portion of maybe alcohol sold could go to health. But also you see that the number of road traffic accidents are growing, and accidents account for a lot of our health budget. And so there could be means to look into the transport industry, and some of that portions of that funding could also be brought in to finance health. But what is clear at the moment is that the user is overburdened. The user is paying too much, but also the over-reliance on donors is becoming unreliable, and donors are slowing down. What that means is that the gap then will have to continue. Yeah. And particularly now with COVID, when the richer people can't go out, some facilities have been closed to and repurposed to just COVID. Yeah. So it's you kind of see that we have the opportunity to look at this problem critically and try to address it for good.
Okay, so Mr. Gaburahi also spoke about the issue of health workforce, and I know Amref has done a lot of work, and the Systems Advocacy Project also had a component of equipping the health workforce with some knowledge and skill on how to handle certain issues as regards SRHR. But Dr. Kagurusi, you can tell us from your expertise and of course the work you've done all over the country. I know we have a shortage already of about 30,000 health workers, but is it because these health workers are churned through a system that is inadequate? Because when you talk about a knowledge gap in providing sexual reproductive health services, one may want to wonder where that problem is. Is it the school they came from? Yep. Is it actually relaxing on the job? Or is it something, is it a new component that we actually never had in our structures? And of course, we know that this conversation is very important to the Ministry of Health. We had invited Dr. Richard Mugahi, the Assistant Commissioner for Adolescent Health and Child Health in the Ministry of Health, but he did not confirm his availability, so that's the reason he's not on this show today. But Dr. Kagurusi, you can tell us what some of those challenges are, why they keep coming up, the knowledge gap especially.
Thank you, Walter. Now the issue of the health workforce is quite enormous, and I think we must break it down, especially in relation to sexual reproductive health and rights-based services. On the global perspective, there is definitely a shortage. The rate at which we are producing the health workers is not commensurate to the population growth. That's one. Two, the education and training of health workers has remained sort of traditional. It teaches the science, but very little is done to teach this health worker on how to handle a client from a rights-based perspective. To expound on that a little bit, a health worker will know how to deal with Walter and myself when we go there for malaria. That's very easy. Malaria is less stigmatized, very clear. High fever, you give a tablet, somebody's better and they go away. But if it's an issue of sexual reproductive health, if it's an issue of sexual reproductive health in nature, that service requires to be tailored to what the client wants, especially if it's a young person. You must know that this young person coming to you has the right to seek care, has the right to information, has the right to even determine how they want to deal with this problem. Young people find a lot of challenges when they go to health facility and they are sitting maybe near the STD clinic with perhaps a relative. It's difficult for them to eventually to come up and say, by the way, I have an STD, because the first question they'll ask, why didn't you abstain? Why are you having this? So they will be judged. But the health worker must also now be able to find out what's happened to this young person, how can I help them? And so the health workforce needs to be in tandem with the different needs that the community actually needs. But also, let's not discredit the health workers. They come from the same communities where we come from. Yeah. We have beliefs, values, and norms. So there needs to be a process of helping the health worker to also understand that right now it is happening, especially now like in COVID, where young people found themselves locked up with violators, those who want to maybe rape, to defile. The outcome is going to be that you are going to see a high number of teenage pregnancies. You're going to see a high number of cases of defilement. It's not the fault of this young girl who has stand up. And if the young girl is coming and saying, by the way, I'm at risk because somebody is abusing me and so on, and I need a contraceptive, you should not judge and say, but no, you're not at 18, don't take the contraceptive, because the problem is already there. So it's not only about the numbers and perhaps the knowledge, but also addressing the issues of norms, values, beliefs that we already still hold, but allow access to young people to access services, because it is the health workforce which determines that. The last point I want to give is about the distribution of the health workforce. They are concentrated in towns for obvious reasons, maybe better pay, better schools for their children, but the burden is actually in hard-to-reach areas where these amenities are not. So something has to be done about the distribution, make sure that even the hard-to-reach people are reached.
Okay, I know Gabula here is itching to interject. You can go ahead.
Walter, I want to add something to what my senior colleague, Dr. Kagurus, has said. By the way, viewers, Dr. Kagurus is my mentor. I worked with Amrit and he mentored me to be what I am today.
Okay.
And as we were coming in, he was saying, Paul, you've also changed, now you're on TV. Anyway, so I want to add something to what Dr. Kagurus is saying. I think even the institutions that are churning out our health workers, there are so many private institutions. How are they being regulated? How are they being supervised? Who is the regulator here? Who is ensuring that the quality of health workers that are coming out of these institutions address the issues Dr. Kagurus is talking about? And then the issue of these institutions were opened, say, in the 60s and the 70s. Are we having change in curriculum to address the current needs of our population? Things are changing every day. But you may find that the curriculum that was developed, say, 20 years ago is the same curriculum that's being taught today. So also that needs to be reviewed. And then the issue of motivation. And you see many professional bodies like the National Midwives and Nurses Council, the Uganda Medical Association, all the time they're in the papers, they're everywhere. They are talking about issues of motivation, issues of adequately ensuring that the health workers get paid, that they work in an environment that reflects who they are. So that is also an issue that compromises the quality of services that are being given to our young adolescents.
Okay. I want to bring in Dr. Orek at this point. Dr. Orek is joining us from Lira, where he works as a medical doctor. And, of course, he's been listening to the conversation. But these last comments, Doctor, directly touch your work, because you interface with the community on a one-on-one basis and you know the challenges that you go through. We would like to, first of all, understand what the situation is like right now on ground with the effect of COVID-19 and all.
Thank you very much, Walter. with the comment that has come up, it is very, very important to note that the pandemic and the lockdown came down here with a lot of changes. And talking about the human resources for health, of course, there was burnout among the human resources. And as people kept on working, the health workers, because of the pressure mounted on the health workers, there has been filling the gaps has not been easy. But for a case like in Lira District, I would like to note here that Lira District has actually closed in the gap in the human resources because recently they had to recruit more staff. For example, hello?
Yes, doctor, go ahead, we can hear you.
For example, the case of Amrit here, we've got a new doctor posted to add on to me, and that has boosted work and that has actually cut down the staff burnout. And other health cadres have been added on to the system. So the pandemic have appeared in its own character, and it has challenged the whole health system. And looking at the sexual reproductive health and rights, that also came with its own challenges. But when we had a touch or a network with Health Uganda, working with Amrit Health Africa, we were able to, through their advocacy, we're able to work on our budgeting and then involve the sub-county. And that also made the work easy because when commodities are not in stock, then the health workers feel the stress because you've got to take a lot of time to explain to the clients. We don't have this in place. We are expecting it to come. And that alone is all stress to the health workers. But with the advocacy, we had the sub-county here in Amrit, which is in Lira District, had to budget even for family planning activities to a tune of over 1 million shilling every quarter. And so that was 4 million in 1 year. So we've had a better drive with the advocacy from Health Uganda, Amrit Health Africa, and other partners.
Okay, thank you, Dr. Orek, for your submission there.
Yeah.
I know something critical is touched about, and which of course comes within the project, the issue of leadership. He talks about the financing, 1 million shillings. We have the situation of Kabale Hospital. It's a hospital that initially did not have budget for SRHR services, but also on top of that, they did not have a substantive district health officer. So the breakdown is from the top. We don't have a DHO, to oversee what is happening in the hospital, and we don't have budget for, many other things. Sexual reproductive health services could just be one of them. I want to hear from Dennis what you think about such an incident. What better way could we handle, even the little finances that we have, the little or, the very limited workforce that we have?
Thank you, Walter. I think the issue certainly of leadership, and I'll also call it stewardship, is really important. You've talked about cases of some areas that do not have a qualified or someone to fill substantially the position, say, of a district health officer. Certainly that's crucial, because then what guidance will be given to the sector. I actually want to relate that more to where I work in terms of medicines, and give the example from there. At the district level, there is actually no one in charge of medicines for an entire district. And yet this is an area where we put most of the money. So who is doing all the planning for this area? who is doing, you've talked about wastages. If you have little money, then you have to use it properly. And therefore, it requires a lot of planning and also facilitation of the few people that are there. If we can go to the issue of primary health care, many of these people are in offices, but the offices are not facilitated. They do not have fuel to move. They do not have funding for outreaches. And therefore, I think for me, what really COVID provides to us is an opportunity to rethink all of this. But a lot, again, begins with the human resource, that you have people, that they are facilitated, and that they plan for the population that, that they have.
Okay. We are going to take a very short break, and when we return, we will speak to Tabu, who is also joining us online. Don't go away. Stay tuned.